Okay, so that's just gone 5:30. So welcome everyone. People are still joining, but we'll kick off and say a very warm welcome to our seventh CfSD National Clinical Pathways webinar. And this is our webinar related to dermatology with focus on areas including acne, eczema, and skin cancers. And these webinars are designed to showcase pathways developed by CfSD in collaboration with clinical colleagues and to provide a forum for education, informal discussion, and your questions and answers. So a little bit of housekeeping before we get started. So the webinar is being recorded and it will be made available on the CfSD website. There'll be an opportunity for Q&A at the end of the session. If you could use the Q&A section, please, at the top of the screen. So rather than using the chat, if you put your questions in the Q&A section, that will be really helpful for us to just track and respond to those either at the end or as the session is progressing. And then at the end, if you want to, we will have the opportunity to raise hands and to ask questions in person. Okay, without further ado, then I'm going to hand over to our first speaker, and I'll hand over to yourself, Daniel. Welcome.
Thank you very much, and thank you to everyone who is joining the webinar today. So the first talk we have is acne. My name's Daniel. I'm one of the clinical fellows in dermatology at the Glasgow Royal. So I'm sure you will all be well versed in acne. It's a very common skin condition in which you have a constellation of different skin lesions, both blackheads and whiteheads, so open comedones and closed comedones respectively. Then you also have an inflammatory component which consists of papules, pustules, cysts and nodules. It's commonly on the face, which is why it's so distressing for the individual it's affecting, but it also occurs in the back and the chest. And these two areas can also be quite difficult to treat with topicals. It affects most people, so I'm sure everyone will have had acne to some degree, but obviously the inflammatory, disfiguring, scarring acne is the acne that we really normally get involved with in secondary care. But you'll see a lot of more minor and mild type of acne in primary care, I'm sure. It can have a large impact on mood, obviously, especially if it's occurring in a group of people when they're teenagers, when they're developing socially, going to school, and et cetera, et cetera. So it is a common problem which people will seek out advice from primary care for. Like I said, it can lead to irreversible scarring. So we would try to prevent that and treat it before it gets to that point. And I'll come on to that later on in our talk. And GPs are typically the first healthcare professionals that a patient will consult with for their acne. So I'm sure you're very knowledgeable about how you treat it in your practice, but if you can take away one or two hints or tips from this talk, then that'd be quite good. So this is just a little diagram showing the types of acne. So you've got normal skin on the left. You've got a whitehead, which is when the pore is sealed, so it'll just look like a little bump on the skin. You've got your blackheads, which again are open comedones, and they turn black because the oxygen in the air oxidizes the sebum. You've then got your papules, which are infected with bacteria, and then the more severe scale is the pustules, which you have your dead neutrophils and just the pussy spots. So these are just some images of, you've got your open comedones there, so you've got the little blackheads. You've got your closed comedones on the right, so it looks, the texture of the skin is not great, it's very bumpy, little kind of white spots there. We then have the papulopustular aspect of acne. So this is all just very inflammatory, red spots, typically on the forehead, the cheeks, and you can also get it on the back and the chest in the papulopustular form. And then this is obviously much more severe acne. So you've got nodulocystic acne there, which will lead to scarring most likely. So this is the most severe form that we have. Just as a little side note for pathophysiology, so there's 4 components. So you have increase in sebum production. So this is why you normally get acne beginning in a teen. The sebocytes are becoming more active due to the hormonal changes within their bodies, so they get more sebum, which will be kind of visible as kind of oily skin. You then get what's called follicular hyperkeratinization. So if you think of it like the skin cells become a little bit more sticky, you get blockage of the pilosebaceous unit. So then you get your sebum building up behind this blockage. You then get C acnes, which used to be called P acnes. They then colonize the follicle because it's a nice anaerobic environment. There's no oxygen. And then eventually you can then have inflammation, which is due to a leakage of the sebum and also cytokines from the C acnes, and you get a generalized inflammation surrounding the pilosebaceous unit. In terms of severity, there is no good universal definition. In research, they use lesion counts, and the NICE guidelines in 2021 also kind of classify acne by lesion counts. So it's mild, moderate, and severe. Mild and moderate are obviously absolutely the same, and it's more of a spectrum. So you can see there that the definition is up to 34 inflammatory lesions and a combination of non-inflammatory lesions such as comedones, or up to 2 nodules. And then severe is the further end of the spectrum, where you have 3 or more nodules and more than 35 inflammatory lesions. We obviously don't expect you to be counting comedones in your clinic. It's more of a feel. So if you can classify it as mild, moderate, or severe, that would be really good. In terms of treatment, I'll quickly just go over the different treatment options we have. So we've got our topicals and our systemics. So the topicals are, for example, some antibiotics. You've got your topical retinoids. You have topical azelaic acid, which is less commonly used, topical benzoyl peroxide, and then we now have combination products where each of these agents is combined in one formulation, which can increase adherence and compliance. And then in terms of systemics, you have oral contraceptives for our female patients, oral antibiotics, and then oral retinoids such as Roaccutane, which is used in secondary care. In terms of the first topicals, we have our antibiotics. So their mechanism of action is just anti-inflammatory and bactericidal against C. acnes. They're typically very well tolerated. They're very gentle most of the time. The main concern relates to antimicrobial resistance, which is more of a national concern now, not just in dermatology, but in other specialties. They are safe in pregnancy, which can be helpful when you have a patient who is pregnant and their acne is flaring. In pregnancy, the acne can go one of 2 ways. It can either go into a more quiet state, or people do see that their skin can flare. And then examples of topicals which are available to you in primary care are things like Dalacin T or topical clindamycin. And then we have erythromycin, normally prescribed as Zinarite, which is erythromycin compounded with a zinc acetate. So it's a bit of an alcohol base, and it's quite good for drying out oily skin. But again, with erythromycin, there's especially significant concerns regarding resistance. The further topical you can use in primary care would be that of benzoyl peroxide. So it's anti-inflammatory. It breaks down keratin. It's a chemolytic agent, and it's also bactericidal. So it will introduce oxygen into that pilosebaceous unit. And obviously the anaerobic C. acnes do not like that. So it is bactericidal. It comes in a variety of preparations. So you have washes or creams. You can do once a day to BD dosing, but it can be quite irritant and it can cause a lot of irritation. The other thing to mention to patients is that it will bleach kind of clothing, bed sheets, towels. And so you can see there on the right, we've got a face cloth which has been bleached by benzoyl peroxide. So it's helpful to warn patients about that. It comes in a variety of strengths, so from 2.5 up to 10%. Most of the studies have shown that lower percentages are equally as efficacious as the 10%, but they're better tolerated. And the important thing about benzoyl peroxide is that it does not drive bacterial resistance. So you can use it in combination with topical antibiotics, or if you have a patient who's on systemic antibiotics, it would be recommended to most of the time use benzoyl peroxide in some fashion to try and cut down on any resistance which might be driven by the antibiotic. You can also use it in a short contact form, so you can get the patient to apply it as a wash, leave it on for up to 5 minutes, and then wash it off. So you do get some efficacy from that without a lot of irritation. And the benzoyl peroxide is also quite good for body acne because you can apply it to a large surface area and then you can wash it off in the shower after a few minutes. The other agent you have available to you is the topical retinoids. So this is things like adapalene, which the brand name is Differin. So they're anti-inflammatory. They prevent the stickiness of the skin cells. So they work on the first precursor lesion of acne, which is the microcomedone. They're usually used at night, and a pea-sized amount to the entirety of the face, not just to individual acne lesions. It can cause some irritation and skin sensitivity and potentially some photosensitivity. So in summertime, it would be recommended to use SPF. And we would recommend starting at a kind of infrequent dosing and slowly building up application just to help with tolerance. They are not recommended in pregnancy. There's no studies of topical retinoids being teratogenous in pregnancy, but it's not recommended. And they can be used as maintenance therapy because obviously they do not drive bacterial resistance. And once a patient has finished a course of Roaccutane, they can go on to topical retinoids to try and just keep any acne at bay. I mentioned about the combination products, so you're probably familiar with these, especially Duax. So Duax clindamycin with benzoyl peroxide. So hopefully the benzoyl peroxide is preventing any bacterial resistance which may be developing due to the clindamycin. You've got things like Epiduo. So you've got your 0.1% adapalene with 2.5% benzoyl peroxide and Epiduo. You can prescribe a 0.3% with 2.5% Epiduo, which is also quite helpful. So that's good for more severe acne. And then you've got Treclin, which is again just a retinoid with your antibiotic, similar to actimycin. So these are quite good because they are formulated in a base together, so they shouldn't have any interactions if you're applying multiple different creams. Sometimes you can get some pilling on the skin and it's not great for the patient, they don't like it. And like I said, this should hopefully increase compliance. In terms of your systemic agents, you've got your oral antibiotics, so they work in a similar fashion to the topicals. The common agents used are doxycycline and linocycline, and I'm sure you're aware of all the side effects. So with doxycycline, you have your photosensitivity and GI distress, the same for doxy and linocycline. They are contraindicated in pregnancy, and you might want to monitor the LFTs if you've got a patient on long-term linocycline. The alternative option normally for you guys in primary care would be that of erythromycin. It's safe in pregnancy, but there are more GI side effects. What's recommended is a 12-week trial, and if there's no improvement within the 12 weeks of therapy, you can try switching to an alternative antibiotic. And if you do get improvement from the 12 weeks, you can continue on for a further 12 weeks to complete 24 weeks in total. For female patients, we do have hormonal treatments. So these work by decreasing the oiliness of the skin. So your ovaries have an androgen function and produce androgens. These will work on the sebocytes to increase oil production. So if we can cut down oil production, hopefully there'll be less acne. So your combination pills are the best for this because progesterone-only pills might exacerbate acne. And you should look at the type of progestin that is in the combined pill because some will have more tendency to cause oily skin and potentially drive acne. So the levonorgestrel is more androgenic. Typically, Yasmin is quite beneficial. So the progestin in that is not very androgenic. And the other option available is Dianet, which can be particularly useful in patients who have an element of PCOS, but there is that risk of DVT and PTA compared to other oral contraceptives like Yasmin. So for mild to moderate acne, what's your treatment ladder? What do you do? So normally we'd recommend a combination. So you've got Epiduo there, for example. So one of the combinations we mentioned on a previous slide you could use. You could also use topical azelaic acid. That is typically well tolerated and it is safe in pregnancy, but can cause a kind of itchiness or burning sensation to the skin when it's applied. And if you deem the patient to have moderate acne, so they're just on that cusp of having a little bit more comedones or inflammatory lesions than what you would imagine for mild acne, you can add in an oral antibiotic. So then severe acne. So this is what I'm sure we'd all agree is quite severe acne. So you've got widespread papulopustular acne on the chest there and then on the cheek. You're having scarring, so this gentleman, you can see he's got a little bit of scarring there. For this, we would recommend a fixed combination, so something like Epiduo, 0.3% adapalene with 2.5% benzoyl peroxide in one agent, and an oral antibiotic, as well as referring on to secondary care for the consideration of a systemic retinoid. And we want to try and get to these patients before they have a lot of scarring, but it's not always possible. So isotretinoin is what is normally prescribed within secondary care for our patients who suffer from acne. It works on all 4 aspects of acne, so it decreases oiliness, it's anti-inflammatory, it stops the hyperkeratinization of the unit, so you don't get the stickiness of the skin cells, and it reduces C acne count by making the skin less hospitable to it. It's normally a 12 to 16 week course, and it's dosed based on weight. We try and get to a target of 120 milligrams per kilogram at the end of the course to try and put the acne into some form of remission. It does have a lot of side effects, and careful monitoring is required, so we monitor LFTs and lipids in secondary care, as well as ensuring that female patients are not pregnant. The side effects are mostly mucocutaneous and can be managed with emollients. We recommend patients stop topical treatment during isotretinoin with the exception of emollients, and we recommend SPF because it can make the skin more sensitive to sunlight. Vaseline can be quite good for lips, and you can put it into the nasal passages as well because it does dry out the lips, it dries out the nasal passages, and you can get some nosebleeds, so we can try and hydrate those areas. That's normally quite well tolerated. It is severely teratogenic, so our females need to be on contraception and a barrier method as well. There's potential mental health side effects, which is a little bit debated, so we do monitor patients' mood throughout therapy, and there is the potential for long-lasting sexual side effects in males, such as erectile dysfunction, which is debated, and I'll come on to those last 2 points in a second. This was just a quick look at PubMed, so there's been 291 studies done with isotretinoin in mood, and no firm conclusion has tied isotretinoin with psychiatric adverse events. The MHRA introduced new guidelines back in 2023, so it's tightened prescribing significantly for patients, especially patients who are under the age of 18. 2 consultants are now required if they're under the age of 18 to approve this. We need to screen for their mental health problems at their initial appointment, so we conduct a PHQ-9 for depression and a GAD-7 score for anxiety at a baseline, and we do it at each appointment that they attend. Because of this, services were initially paused, but we now have, at least in GGC, an isotretinoin service up and running, and I'm sure each of your respective health boards will have some form of service now up and running, but there is a backlog. So if you're referring for isotretinoin, it would be really helpful if you can ensure if the patient's female, if they are on an adequate form of contraception. It'd be helpful in the referral to know about their baseline mental health status, highlighting if they've had any previous involvement with CAMS or general adult psychiatry, and just continue them on treatment as per the severe acne protocol, such as a combination topical and an oral antibiotic. So this quickly for 2 cases. We have Jessica, so she's 17, she's had grumbling acne since she started menstruating. It flares mostly at the time of her menses. It's mainly in the jawline. She has a few scattered closed comedones to the forehead. Thankfully, she's had no scarring. She's not tried any topical treatment yet, and she's not on an oral contraceptive pill. So if you saw this patient in primary care, you could consider an oral contraceptive pill, the combined pill like Yasmin. That would be quite good, especially if it is on the jawline and it's flaring at the time for menses. And you could also add in something like a topical retinoid for the closed comedones that they have to the forehead. But that wouldn't need referred to secondary care in the first instance. And then we have John. So John's 16 years old. He has a family history of severe scarring acne. He has good mental health. He's had no mental health history. He does have some ice-pick scars, which shows that acne is severe, and the only topical he's using right now is Acnicide, which is just a benzoyl peroxide wash. So for John's case, he's obviously got severe scarring acne, so he needs to be seen in secondary care. So we'd recommend treating him as per the severe acne protocol. So a combination topical would be good, an oral antibiotic, and a referral to secondary care where we can then consider isotretinoin. Okay, so that was a quick whistle-stop tour. So I'll hand over to Nadia and we can come back to any questions at the end of the talk. Thank you very much for listening.
Thank you, Daniel. I'm just going to talk a little bit about eczema and practical tips which hopefully will benefit you in clinic. I'm one of the ST5s currently working at the Royal Infirmary. Asthma as a background tends to affect those who are atopic, so those who have hay fever, asthma and food allergies. It usually starts in infancy, although it can occur later, and generally settles in late childhood or adolescence, although in some, unfortunately, it does continue onwards. It is a very complex interplay between environment and genetic factors, and you'll often get patients asking you in clinic, is there one thing that I'm doing wrong? There must be a cause for this, and it just requires a lot of counselling to the patient to tell them that there's not one cure for them, unfortunately, that will solve this problem. It's not one thing they must avoid. Unfortunately, it's likely a multitude of factors and often runs in families, unfortunately. In patients with eczema, it usually presents as an acute flare on a background of chronic disease. An acute flare would show as acute bright red erythema and exudative, so looking weepy and crusted. And in those more chronic dermatitis, you'll see lichenification, it will be scaly and there'll be fissuring where there's cracks in the skin. Eczema comes in many different forms, and I've got several pictures all taken from DermNet just to display the real variety of eczema presentations. In the top corner, looking at, I think, what is an arm or a leg, most likely, we see asteatotic eczema, which has got that kind of crazy paling appearance over the skin, and it tends to affect the elderly in dry, warm, humid environments. We also, moving in from the middle one at the top, show discoid eczema, so discrete circular lesions, very scaly and erythematous. And then next we can see periorbital eczema, where there is general erythema around the eye, and there's associated swelling with that as well, and not particular scale in this patient. Moving directly below that, we have pompholyx, so very itchy blisters on the palms generally. And this is a picture over somebody's sacrum on the middle lower picture, showing a kind of a papular excoriated type eczema with more diffuse erythema. You cannot really tell where it begins and ends. And you can see increased skin markings on the lower back, which is in keeping with lichenification. And then that very classic picture of eczema on the bottom left corner, showing eczema at the flexure, where we commonly see it, showing again subtle kind of increased skin markings, very non-specific erythema, and you can tell it's excoriated. And again, it can present again in many different people. So the larger picture shows a more kind of papular eruption, but you can see in this person who has skin type 6, you aren't seeing much erythema, and inflammation be a bit more hard to detect, but you're seeing that texture difference. It just doesn't look normal, it looks irritated. You can see that the surface is bumpy. And then in the left picture, this is a patient who has had inflammation, and on resolving, there's the post-inflammatory hypopigmentation. So although you're not seeing that redness, you can tell that the inflammation has been there. And again, in the lower picture, just on the forehead of this patient, there's post-inflammatory hyperpigmentation. In the paediatric population, it generally presents in infancy on the cheeks and on the flexures, and generally spares the napkin area, although there are many other causes as to why there may be a rash in that area. It will often dribble, and food, messy toddlers eating their food will cause periorbital involvement, and often onto the chin and onto the sternum of the chest. And the child at the top shows that classic bright red cheeks with scale, Looks like it could almost be a bit weepy at times in this poor child with eczema. And then the child at the bottom, you can see that classic, again, lichenification, those increased skin markings, and a few papules on the trunk if you look very closely. And of course, the picture shows them mid-scratch as well. So their nails will be shiny from scratching because they're constantly buffing their nails. So treatment for these patients is a multi-pronged approach and often requires a lot of time and input with a patient, and often will require more than one appointment just to make sure the patient is comfortable with their treatment plan. And the mainstays of treatment are generally emollients and topical corticosteroids. The best emollient is the emollient the patient will actually use. So if you insist they use what you think is the best one, but actually don't like it, they're not going to use it. And generally, we would prefer ointments over creams and over lotions, and that's due to the reduced water content. However, if a patient is refusing to use something because it's too greasy, you do have to work with the patient and find the one that they will actually apply onto their skin. You want to encourage liberal daily use. It's not going to do any harm by over moisturising, and suggest to patients with certain ointments like hydromel ointment that they can use this also as a wash, or the patient may prefer a more specific soap substitute like Dermal 500 or QV wash. With topical corticosteroids, there is the steroid ladder scale, moving with Dermavate as the strongest, Bentonavate as a potent, Humavate as a moderate, and hydrocortisone as the weaker topical steroid. You would encourage a person to use their treatment for 48 hours after their flare is controlled, just to make sure it's stable, and then you would want to wean down the use. For delicate areas, you need to remember that they require a more weak steroid, like hydrocortisone, or a very short course of a moderate steroid like Humavate. However, this can add complication. You need to make sure the patient's got a specific one for their face versus their body, so it does require a lot of time and counselling to explain to the patient how to use specific products and where. Another product which is popular is topical calcineurin inhibitors, more commonly Protopic, and these are very useful as second-line agents, typically used in those with facial eczema and as maintenance therapy, often on the face. You would generally avoid if they had evidence of infection at that point. If the patient uses maintenance and they come in with an infection, just advise them to withhold it for that time and use a steroid as an alternative. And you must warn the patient about initial stinging. It could feel kind of burning or irritation, and often they'll use it once, hate that feeling, get worried that they've got an allergy to it and stop it. But if you warn the patient that's to be expected, hopefully that will promote ongoing use. If they do find it irritating, I always suggest using it at night anyway, so they're hopefully sleeping off the kind of stinging feeling. You would reassure them that after a period of use, they do get used to that sensation. And if the patient is really struggling with it, you could even suggest the sandwich methods where you use ointment on top of the skin, calcineurin inhibitor in between, and then more ointment over the top, just sandwiching it in just to try and reduce the side effects of the stinging. As I said, commonly we use Protopic or tacrolimus, and it comes in two different strengths. The weaker strength is licensed from the age of 2, and the higher strength from the age of 16, although in secondary care at the Children's Hospital, we often use the higher strength in children much younger, just off licence. The other option is Elidel or pimecrolimus, which is licensed from the age of 3 months. So it's a consideration of a good option in that age group, but we're able to target with Protopic. There can be lots of different presentations of eczema, and often a patient will come to you and say, the cream you've given me has worked great, but when I stop it, my skin flares again. And you need to consider the fact that eczema is a chronic condition. If you stop treatment, it is expected their skin will flare. And so we need to explain to patients the step down kind of treatment plan, where they use a higher strength for flares and then step down to a lower potency corticosteroid, and often consider using that as intermittent treatment on either 2 consecutive days of the week, so like a Saturday, Sunday, or just twice weekly spread amongst the week to hopefully prevent any further flares and just continue long-term maintenance treatment. Considerations in eczema is complications, and one of the bigger ones is secondary infection. As you can see in this picture, this patient has unfortunately herpes simplex infection or eczema herpeticum, as you would see in a patient with eczema. So it's a widespread virus spreading amongst this patient's face, unfortunately. On top of that, at the eyelid area, you can see yellow crusting, which shows impetigo and therefore secondary bacterial infection as well. If you were to see this presentation in your clinic, the first thing you must do is refer to on-call ophthalmology, because this is involving the eye and it must be checked by the ophthalmologist. Again, if you were to see any yellow crusting or any evidence of herpetic infection, then you should please swab it and send it off to the labs just to confirm that you are treating what you think you are. If somebody has localized bacterial infection, you can consider topical antibiotics, and that's, for example, Betadine C or Fusivet or Trimivate, something with a steroid and an antibiotic in it. However, if the infection is more generalized or is not clearing with topical treatment, please consider a systemic antibiotic, just based on local guidance. And again, as if you consider eczema herpeticum, consider this if it's an acute onset painful rash, if there's uniform grouped vesicles or erosions, and at that point, please swab, prescribe cyclovir, and refer onwards to dermatology. And if close to the eye, also onto ophthalmology. The referral criteria is quite vague and is really based on individual patient in front of you, but please consider a referral if there's moderate disease and they've failed on multiple treatments in primary care. Consider referral if there's severe disease and it's not responded to optimum topical therapy, which is generally a potent corticosteroid. And emergency referrals would be eczema herpeticum and erythroderma. And erythroderma is defined as more than 90% body surface area involved. And at this point, we need to consider, is the patient, you need to consider complications of erythroderma like dehydration, secondary infection again, hypothermia, and just consider the patient as a whole rather than just focusing on the skin, because they could be more unwell than just the skin. They could be losing all their body heats and unfortunately becoming dehydrated. They often present as very shivery. And again, consider referral if there's diagnostic uncertainty. There's some really great resources for eczema patients, and NICE guidelines are very good. There's the Primary Care Dermatology Society, which has a really good, is a really valuable source of information for not just eczema, but for other conditions. And DermNet website, of course, for all dermatology conditions. If a patient's coming to you, you need to consider them as a whole and think about the impact it's having on the patient. Are they up all night not able to sleep because of itch? Is there an impact on their schooling? Are they actually getting to school? Are they having many days off? And you need to think about the parent. Is the parent, if it's a paediatric case, if the parent's very stressed or worried, you need to think, what impact is this having on them? Often the parent is wondering if they're doing something wrong, if they are not good enough at applying creams. And it's worthwhile exploring these concerns, because often there is a lot of guilt underlying, and because giving a little bit of reassurance, explaining the chronic nature of this disease can be very helpful and reassuring for a patient, and can hopefully lead to improved relationship between the patient and the clinician. When you're taking a history from a patient, you need to check what treatments they've previously used, what is currently being used, and if they've used anything before which they found helpful. So it's good to get an overview, because there's no point putting them back onto something which they've used before and they absolutely hated. You need to know how long the patient is actually using the treatment for and in what quantities, and where they're applying the treatments. And it's always worthwhile establishing patient expectations and any specific questions they have. Their expectation may be that they use a cream for one day and it completely resolves, but that's not realistic, and you need to align expectations and explain the nature of eczema. So when it comes to antihistamines, there's often, these group of patients are often on antihistamine, especially to help them sleep. There's no real evidence for the role of antihistamines except for the use of short-term use for sedating antihistamines to improve sleep. So it's worthwhile reconsidering the ongoing requirements once we've got their flare settled. You need to ensure that you're prescribing adequate amounts of treatment. These patients will go through vast quantities, especially if they have a large body surface area involved. And the general rule of thumb is We expect people to use 500 grams of emollient per week if it's generalised eczema, so a lot more than what you would think. So please ensure that when prescribing, we're giving adequate amounts. Try to avoid aqueous cream as a leave-on product, as it contains SLS, which is an irritant for some. And you need to consider allergic contact dermatitis if the condition is not improving or there's a change in distribution, like it's on the hands and the face, and that may warrant referral to dermatology for further consideration. Occlusive dressings can be quite useful. It helps with penetration of the steroids, and it also creates a barrier to help the patient stop themselves scratching and break that itch scratch cycle. Tubular dressings, so the blue line dressings, are really useful on the arms and legs. People often wear vests as well, cotton vests, and sometimes people employ the use of garments like the skinnies garments in the paediatric population. Question people always ask is about bathing and if they're doing enough of it, if they're doing too little of it. The natural inclination in some people seems to be trying to bathe less, but actually the guidelines is to encourage regular bathing with lukewarm water and to limit the amount of time that you're actually bathing for. This hopefully prevents the risk of infection. So please do encourage regular daily bathing, as certain people just really try to pull back on it, unfortunately, which can result in chronic recurrent infections. You may also wish to consider bleach baths in those that have recurrent infections. This is a little diagram on how much somebody should be using of their steroid, so often more than they think, and the fingertip unit generally is 1 fingertip unit should cover 2 palms worth. So that's kind of the general rule of thumb. And when prescribing your steroids, I would always encourage the use of ointments if you can, because they're more efficacious. They've got more efficacy versus the cream version. Once daily use is normally sufficient for the management, but that is again dependent on the patient response. Referral can be really useful if an easy score is included, and there's many websites online which can do an easy score for you, but it looks at the head and neck, the trunk, the arms and the legs separately, and you tally up a score for them, and it looks at the degree of erythema, how thickened and indurated their skin is, if there's any evidence of excoriations, and the level of lichenification as well. So it's a really good thing to start to do when you're looking at a patient, because it produces a standardized score, and if you see them back in clinic, you can quantify as to how much improvement or lack of you've achieved with your treatment plan. And as I said, there's many different websites which have pictures that you can refer to and pick the right picture that matches your patient, and then does an automatic score for you. That was my whistle-stop tour of eczema. I think there'll be questions at the end, and I'll hand over to Dr. Fiona McDonald.
Thanks very much for that, Nadia. So if I haven't met you already, I am Fiona McDonald. I'm a consultant dermatologist in GGC. I'm the National Clinical Lead for Dermatology for CfSD, and I'm also the West of Scotland Skin Cancer Lead, because I didn't think I had enough things to do apparently. So I thought I would talk to you about 3 topics in the Right Decision Service, and try and overachieve and do a canter through skin cancer. So I will tell you about no commercial interest, no conflict of interest other than my ongoing obsession with digital dermatology, and please don't share any of the images or talks without consent. So our aim is that the new guidelines, a bit about cancer, the Right Decision Service, and obviously DigiDerm. When we're talking about skin cancer, we usually mean the big 3. So BCC is high volume but low risk, SCC high volume and increasing volume but moderate risk, and melanoma is the lowest volume but the highest risk. And these are all covered separately in the Right Decision Dermatology Service section in the Right Decision app. The sort of non-melanoma skin cancer data is less available, but the BAD, the British Association of Dermatology, estimate there's about 250,000 cases in the UK, but 180,000 of them are BCC. So they don't really record BCC as a cancer group because it would dwarf all other cancers. It is that common. Interestingly, they predict that the incidence of non-melanoma skin cancer deaths will overtake melanoma deaths, because non-melanoma skin cancer is increasing, and by that we really mean SCC, but there are static deaths in melanoma due to combination of factors that we probably can't get into today. But there has been an increase in melanoma in Scotland, but it tends to be in a lot of cases at an earlier stage, which is much more eminently treatable. A background to the service: we are nationally considered a fragile specialty with significant senior staff vacancy nationwide. And although the 14 days is not a government recorded target, trying to see USOC referrals within 14 days was the heady heights of pre-COVID, and many boards are struggling to meet that target now, GGC included. A USOC referral, these are, you might have heard them being tracked. This means that someone manually follows the pathway of this referral to make sure that they meet the 31 and 62-day targets, and they are prioritised over other referrals. So the urgent referrals and the routine referrals, they will be bumped in favour of USOC referrals if we need more capacity to get those patients through, because the expectation is the majority of our cancers will be in that grouping. So lots of USOC referrals means that the urgent and routine waits get longer. So just for instance, we could have a concerning pigmented lesion, and it's a 65-year-old male who's noted a 6-month history of a new pigmented lesion, and the examination shows a lesion that's approximately 1 centimetre. There isn't a photograph with this. So when the patient comes, it could be this, which is a seborrheic keratosis, didn't need to be seen, could have been reassured. Or it could be this, which is a melanoma and needs to be cut out as soon as possible. So same history, same patient, the only thing that's allowed us to tell a difference is a good quality clinical image. Mention the cancer referral guidelines. They were launched in September. They are going on to the Right Decision Service, as well as the dermatology pathways, and also the referral protocol. So I'll just move into a fourth topic, which is benign lesions, and the referral pathway for benign lesions will also be joining RDS as well. And I think they're just simplified. I think a lot of people seem surprised that SCC is now USOC, etc. But I think it's just easier to say suspicious of SCC versus keratotic nodule. I think it's just much clearer than it was before. I don't think the list has changed that much. If you are interested in seeing the dermatology pathways, I've tried to put the page up at the end, but that's the dermatology sort of pathways that we moved from our original app, and also used the BAD pathways that developed as well. We adapted them for a Scottish version, so we are adding to them bit by bit. So hidradenitis will hopefully be joining the group soon. So it is any skin or nail lesion suggestive of melanoma, suggestive SCC, BCC invading a potentially dangerous area, biopsy-proven lesions, concerning lesion suspicious malignancy, or a concerning lesion in a compromised patient. So that's a new criteria. And what that means is that the majority of BCCs, that 180,000, do not need to be USOC referrals. They can be referred routinely, and the head and neck, whether they're routine or urgent, can depend on the site, size, rate of growth, and confidence about the diagnosis. So BCC, if that's been there for a while, it's on the temple. That might be an urgent because it's head and neck, but it's certainly not a USOC. Coming back to the photographs, this again is not a USOC, but if you describe this on the right side of the nose, what you wouldn't tell us is that this is very close to medial canthus and actually needs a plastic surgeon, because you need to clear a few millimeters around there to make sure your margin is clear, because you're almost certainly going to secondary repair on this. So that's out with the realms of most dermatologists. So if I saw this in a vetting, I would pass this on to plastic surgery, because the patient doesn't need to wait on our list to be told they need to see a plastic surgeon. They could go straight onto a plastic surgeon and have treatment the first time around. Superficial BCC, this can be treated non-surgically, so there are lots of options in dermatology for patients with this, but this can be a routine referral. And obviously, again, coming back to, if you describe this on the eyelid, this is actually on the lid margin, and this would be more likely actually oculoplastics than plastic surgery. So again, we can decide the right place for this patient to be directed based on the image of actually where the lesion is. It's not often about cutting a lesion out, it's about how you're going to repair it. Squamous cell carcinoma are not tracked as though we'd like them to be. They don't have QPIs, although we'd like them to have them, and they will account for the majority of the non-melanoma skin cancer deaths. We are rotating them as USOC, as they can be more rapidly growing, disfiguring, to manage surgically, and also metastasize, particularly to nodes. So this is an SCC on the lip. But again, with a good quality clinical photograph, we can tell you this patient needs to go to oral maxillofacial surgery. This is not something for dermatology to look after. These patients should be straight at OMFS. This may well be even a congenital acanthoma looking at it, but again, it's on the nose. This patient's going to need a secondary repair, and this patient could go straight to the plastic surgeons and have that done. You don't really need to do a biopsy or see a dermatologist with a good quality clinical image to know that that patient needs to see a plastic surgeon. This is a less, I'm not entirely sure what site this is, but it's a body site. So this is something that, again, SAC, but dermatology could eminently remove, hopefully in a one stop. We put this patient as a USOC referral, they're seen in our clinic, hopefully biopsied in the day, and treatment is complete. This is a bit of a kind of red herring, so you might think this is a BCC, but it's very deeply eroded, and there's a bit of tethering at the edges, and this is in fact an SCC, so beware of the SCC that masquerades. These will sometimes grow a bit faster and a bit deeper ulceration, and that might give cause for concern. But then you have Bones disease, which is a pre-invasive squamous carcinoma in situ, which has a very low conversion rate to SCC and can be treated with non-surgical options, even in primary care. So again, we might be able to write back to you and say, try this treatment and let us know if it doesn't work. Actinic keratosis, again, with good quality clinical images, we can give you recommendations on one of the topical treatments. We'd normally suggest Effudix if you can get it. Our beloved Effudix has been out of stock for quite some time, but there is some alternatives, and these people can use topical treatment on these areas. But if you are going to treat it, beware that this patient has got what we call field change, which means that the whole area has a degree of actinic damage, so they are likely to get a reaction on pretty much every bit of skin that they put the treatment on. So they just need to be aware of that, and I often will split the face or the scalp into segments to stop the patient having a really uncomfortable inflammatory response, because essentially this whole area is pretty much actinically damaged, with some areas a bit more keratotic and some areas we've got almost eroded, but the whole area is heavily damaged, and will I sometimes refer it to the patients as lighting up like a Christmas tree with the topical treatment, because the whole area is going to pick up the treatment from that point of view. Melanoma is obviously our highest risk. It's a QPI, it is tracked, and we have to report on our melanoma performance. The ABCDE was adopted for the cancer referral guidelines, and I think it's easy, and I think it's quite useful for patients as well. So asymmetry, the border, the colour, diameter, and E is for evolution. There are not that many invasive melanomas that are less than 6 millimetres, I'd have to say. So if you look at this one, this is a very good, this ticks all the boxes. Is it asymmetrical? Yes. Is the border all over the place? Yes. Is it one colour? Absolutely not. And actually I often say to patients the extreme of colour, so black, white, red, those are the things that are much more concerning than graduations of colour. And obviously there's a fair chance this will have been changing as well, and it is significantly bigger than 6 millimetres. Beware the funny looking nodules, and sometimes if you put the dermatoscope on these, you'll find these items are pigmented, and these can be nodular melanomas, but these can be quite thick lesions. So just be aware of that funny looking thing that is growing quite rapidly and has a sort of dark purplish or brown hue to it, because that can sometimes catch you unawares. We see quite a lot of nails with linear melanechia, and again, sometimes it's about the context. This patient has lots and lots and lots of melanechia in a patient who's probably got type 4 or 5 skin, so that is actually could be normal for them, not any problem, as opposed to this one, which is a melanoma, and you can see these thick dark bands that are very different from pale multiple thin uniform bands that you see in the benign disease. And a lot of our queries will actually be hemorrhage, and you can see the difference. This is a blob. It is not linear. It's not attached to the nail bed at all. There's no pigmentation at the nail bed, etc. The patient's fingers will probably have a history of trauma, but they often don't have a history of trauma in toenails. But actually, when you look at the dermatoscope, you can see the globules of blood and the discoloration. But the fact that this is a sort of circular area and completely separate is often the dead giveaway. It takes much longer for nails to replace themselves than you actually think, and it can take up to a year for a nail to fully regrow. So these areas do not disappear just as quickly as people think. They will have to grow out with a nail, so it can take some time. And obviously, again, good quality photograph. These are some nice seborrheic keratosis. So we could reassure the patient that these multiple pigmented lesions are absolutely nothing to worry about. Other lesions, again, the pink nodule. Beware the pink nodule, that can be lots of different things. So that pink growing nodule you always want to worry about. And this is what we call a Merkel cell carcinoma, which is an extremely aggressive and very poor prognosis tumour. But you can just tell looking at it, this thing is probably growing very rapidly because few people will tolerate this on their temporal for a long period. It's very friable, it's ulcerated and eroded, it is a nasty looking tumour, and actually Merkel has a poorer prognosis than melanoma, unfortunately, with lots of nodal spread. In fact, they talk about the new guidance says sentinel node biopsies for Merkel, and they used to talk about irradiating the nodal beds prophylactically as well. Pyogenic granulomas, so younger people, on hands, history of trauma, these are all reassuring features, but just beware of the very friable hemorrhagic lesion on an elderly patient's trunk, because that can occasionally be an early melanotic melanoma. So this one I'd be fairly happy with, but if this same lesion was on an 85-year-old's back, I would excise it for the base because there's a good chance it'll be a melanoma. And again, the classic amelanotic melanoma. Digital dermatology, if I haven't mentioned it at all during this talk, it was the first start to finish project from the National Innovation Group, ANIA, and it was funded by the Scottish Government. They procured a company called Consultant Connect that you'll be familiar with, and some boards has been using already. And the images are pass-through, which means if you use your phone to take these images, they never touch your phone memory, and you can be secure that information governance is in place. They're not on your, nobody else can see them. They've gone and they're ready for the referral. And in the fullness of time, they should be going straight to the National Digital Platform for everyone who has an interest in the patient's case to be able to review them. So that's the pathway. So very straightforward. You see the patient, you take the photograph. At the moment, you upload it onto the referral, but in the fullness of time, we're hoping that that will be up onto the NDP. We're waiting for development of the NDP. And obviously, we can prioritise our cancer cases. We can advise on patients who need to see another specialty, or we can arrange for the patients to be seen in clinics. And although I have talked about lesions, rashes can be equally important as well. I would mention I'm sure it's been mentioned a few times where there was a very excellent picture of Lyme disease on a routine referral. So by the time the patient had waited to be seen, the rash would have been gone, the diagnosis would have probably been missed. But an excellent photograph was sent, and I phoned the patient's GP, and the patient was started on antibiotics, crisis averted, and the patient was able to be treated early. So don't forget your rashes when you're taking photographs. I know there are some teething issues, and and Consultant Connect are prioritising them and working very hard on sorting these issues out, particularly via authentication for GPs who don't have a fixed practice, etc. And in the fullness of time, not having to attach the images manually, but having them on an NDP. So these are all priorities that we're working on at the moment. And I thought I'd just finish with a quick photograph of the National Digital, the Right Decision Service, sorry. So there's 273 resources now. It's growing regularly, and within that you can find our dermatology page that I showed you earlier. And that is us.
Thanks so much, Fiona. I'm going to thank Daniel, Nadia and Fiona for a canter through at breakneck speed, but in absolutely the right level of detail of acne, eczema and skin cancer. We have got a little bit of time left over for questions, and we've got some questions in the chat. So I'm going to go through the questions in order, if that's okay. We had a comment from David Heron there around making sure that we use the formulary recommended combined oral contraceptive, which I think is absolutely correct, and a helpful reminder. So I think that's just useful reminder there. We've had a question around waiting times for routine and urgent referrals for adults and paediatrics. Fiona, do you have a sense of that across the country? I mean, you mentioned it's challenging.
Yeah. It's difficult because a lot of smaller boards, paediatrics will be part of the adult service. It's mixed in, so it's difficult. So it'll be the same. Glasgow is obviously big enough to have both. I think the paediatric referrals are in Glasgow. I don't know paediatrics is better. I can only comment for Glasgow and the west of Scotland. I know that routine referrals are close to a year. They are more than 52 weeks in many of the boards. And urgents vary again, whether it's lesion or not, but urgents are vary. But you're talking several months now for an urgent as well. It's a very difficult time for dermatology, and that's why we are very keen to use photo triage and use vetting and active referral, sort of active clinical triage to not have people sitting in a list. It's very unsatisfying for the patient to wait 52 weeks to be given a topical treatment they could have been given at the start. And obviously we want to make sure our cancer patients are managed early.
Brilliant. Thanks very much, Fiona. I'm going to keep going through the questions we've got in the Q&A section. We've got a few questions around eczema, so I'll probably come to you, Nadia, for those. We've got a question around referrals to the allergy clinic when infants present with eczema. What's the relationship between dermatology and allergy clinic these days, and sort of kind of when do the two cross overlap, I guess?
Well, they're two separate services, and it's mainly in the paediatric sector this is more relevant. I generally work in the adult sector, so may not be giving up-to-date information about this. But generally we see a bit of kids with protein allergy, which is mainly supported by the dietitian. And obviously type 1 allergy would be referred to the allergy clinic and not to dermatology. So it really just depends on kind of what's going on with the patient, their history, as to if we investigate in dermatology for any food allergies, but it certainly wouldn't be for type 1 testing.
Yeah, that's great. Thank you very much. We've got a question around advice around the management of eczema around the eyelids.
So
specific?
A weaker topical corticosteroid like hydrocortisone is more appropriate. However, if there is an acute flare, like a 3-day treatment of Humavate may be appropriate, just depending on the level of erythema. And then maintenance treatment can be used with hydrocortisone or a Protopic just to prevent skin thinning, as Protopic doesn't have that complication with long-term use.
And I would just remind people that if you are prescribing topical steroids to the eyelids, to remind the patients not to get it in the medial canthus, and to make sure that you avoid that area and very, very deliberately, very carefully.
Thanks very much, both. And I guess linked to that is the question around tacrolimus, and I guess there'll be maybe there's a variation in terms of how confident people feel using tacrolimus topically, or how much people use it. Question around pediatric eczema: is it reasonable to use in pediatric eczema in primary care, from your perspective?
I don't think it's unreasonable. I need to check the exact licensing. I know that adults are allowed to, that for adult patients you're allowed to initiate. So I need to double check about whether you're allowed to initiate it in pediatric eczema. But we it is licensed for some of the pediatric groups. So I think if it's licensed and you feel confident enough about it, that's fine. But you can check your local formulary as well.
Thanks. It may be another case where photo triage may be helpful as well. I guess that you may get that recommendation back from a dermatologist. So that's kind of helpful.
Yeah, we often get fit referrals like that, saying that the GP is not that confident initiating it, but they will initiate it if we have a look at an image and give advice, which we can do.
That's brilliant, thank you. A question around acne. I think that's a good question. It was one that I had on my mind. So what's the role, or if any, of trimethoprim in the management of acne?
Way down the line. Sorry, I was going to answer that, but way down the line. We tend to use it as a drug if the patient isn't suitable for isotretinoin. So it's a drug that has quite a few side effects. It's a drug I'm personally not a fan of. For a variety of reasons. I've seen quite a lot of morbidity associated with it, more than other antibiotics. So I tend to reserve it if we are starting to struggle with anything else. And looking at it as an option. Obviously now for female spironolactone and things are coming on board, I'd probably put spironolactone on top before trimethoprim.
Thanks. That's a really useful question, because I suspect others will have been having similar thoughts. Question around Zinerit, and would that still be an option for mild to moderate acne? Daniel, I know you mentioned that on its own or in combination with others.
It would be okay, yeah. It's obviously got a dual mechanism of action, so it would be okay. You could also add in a benzoyl peroxide wash a few times a week just to try and cut down on resistance. But yeah, Zinerit is typically very well tolerated.
That's fantastic. Thank you. I think that's probably all the questions we've got, but certainly you've got the email address there if you want to send any further questions, or we can send those on to Fiona, Nadia and Daniel for any kind of further advice or response, which I'm sure they'll be happy to do. I think it remains mainly just to thank our three speakers who've been fantastic. I just would be grateful if you would take the time to scan the QR code or click the link there, which will take you through to a feedback form. It's really useful for us to understand in terms of timings, content, what's useful and what other topics would be of interest. The next webinar that's there, there's a link attached and the QR code for functional neurological disorder, which again I think is another area that is very relevant to primary care and something we see quite frequently. We've got some other webinars lined up, dates to be confirmed, including ENT, gynecology and chronic pain. So thank you all for your attendance and to our speakers, and we'll look forward to seeing you at the next webinar.